Hello, I'm Loretta Horton, co-chair of the Allied Health Department at Hutchinson Community College, and I welcome you today to the first segment of Health Matters. And today I have two guests with us, Dr. Chad Isinghoff from the Hutchinson Clinic and Teresa Pauls, who is the Respiratory Therapy Program Coordinator here at the college. Dr. Isinghoff received his medical degree from the University of Kansas, and he's been with the Hutchinson Clinic for 24 years.
That's correct.
And Teresa is also a graduate of the University of Kansas, and she's been a respiratory therapist for about 25 years, and she's just recently here at the college to help start our respiratory therapy program. Today, Dr. Isinghoff is here to talk about pediatric asthma. And I was wondering if you can tell us, Doctor, do allergies cause asthma?
Well, not particularly. They're related, but not. One is not. They're not causal per se. You know, allergies are really the body's response to environmental things that normally don't cause a problem. Things like pollen and bee venom and certain foods that are typically harmless to people. Sometimes the body will recognize those as abnormal and will develop allergies because of the antibodies that the body produces. Asthma is a pulmonary disease that is caused by restriction or narrowing of the small airways in the lungs. It can be related to allergies, and it certainly can have some allergy triggers, but it's not solely an allergic disease.
Okay. What are some of those triggers?
Well, a lot of the triggers can be environmental. Certainly there are certain foods that can trigger asthma, things like sulfites in foods. Certain foods themselves can trigger asthma. Certain medications can trigger asthma. For example, aspirin is a very common trigger for asthmatics. But a lot more of the symptoms revolve around environmental irritants like smoke or smog or sometimes pollen's in the air. Sometimes asthma can be elicited, or the asthmatic response can be elicited by things like exercise or cold air.
I see. I've recently read that children who have been diagnosed with eczema have a greater chance of developing asthma as they get older. Is that true, and why would that happen?
Yeah, that's true, and that falls into that category of asthma that's related to allergies. Eczema, or what we would consider atopic dermatitis, is an abnormal skin response based on an allergic response within the body, and so it falls into that category of asthma that's probably related to allergies. So there's a high connection between kids who have atopic dermatitis or what we consider childhood eczema and allergies and asthma.
Okay. What are some of the symptoms of asthma?
Well, everybody thinks about wheezing, but commonly what we see, and there's a spectrum of symptoms. In very young children, we may see wheezing, but most of the time what triggers our awareness of asthma is our recurrent infections, or what we would consider like recurrent bronchitis, where kids come in with a cough and congestion, and they may or may not have wheezing, but recurrent episodes of that can certainly should raise the level of awareness about whether a child may have asthma or a reactive airway disease. As the kids get older, probably the more common symptoms are cough at night, cough when they're out running around, or cough with exertion. A lot of kids will start coughing if they laugh, or if they start crying, they'll start to have a cough. And those are usually the signs that we see prior to the onset of full-blown wheezing and more the traditional symptoms that we see with asthma.
Okay. Is there anything that parents should look for in particular other than the cough?
You know, certainly sometimes we see asthma tends to run in families. And it's not inherited like eye color is or hair color, but I think there are genetic dispositions to asthma. And so if there's a strong family history of asthma or atopic diseases like eczema, that is one thing that parents might be, make their physicians aware of. Then the other things are just the common symptoms like recurrent episodes of coughing or coughing at night and coughing with exertion, and a lot of times what we see are just kids with diminished lung function who aren't able to keep up with their friends.
Sometimes we hear that children will grow out of asthma. Is that true?
No.
Oh.
in 2 words, no. That's a myth. If you have asthma, you have asthma. The fact is that if it's controlled well when you're young, that it becomes much easier to control. And in fact, we have a lot of kids who are controlled well, and for whatever reason, when they go through puberty, asthma becomes much easier to control. And they may not need to be on chronic medicines through adolescence, young adulthood, and on into adulthood. But you do not outgrow asthma, and once you're an asthmatic, you're always an asthmatic.
Okay. Are there any particular tests that are done to determine if a child has asthma?
Not really. There are in adults, but they're a little bit more complicated to do in children. And so basically what we do is we look at how they respond to medication. By definition, asthma is a reversible disease. And so we put children on medicines that we normally use to treat asthma, and we make the assumption that if they get better, then that's probably what they have. And it's also related to longevity also, that if they have recurrent episodes of coughing or wheezing that get better with these medications, then it's fairly safe to make that diagnosis. Although we're a little bit tentative to label a child as an asthmatic, because once you have that label, it's very hard. I mean, you can't get rid of the label. And so, if we err to probably not diagnose it as quickly as maybe we should, although most of the kids who have asthma or recurrent airway disease, reactive airway disease, are treated appropriately. They just may not get that label because of the implications later.
So what's the common treatment for asthma?
The treatments have changed dramatically over the last 24 years. Currently, there are several lines of treatment, but primarily asthma is a disease process caused with basically two mechanisms in the pathophysiology. One is restriction of airflow, or the smaller airways become narrow, and then there's a second inflammatory process around those airways, or in a sense, infiltration of white blood cells around those airways that makes them less responsive to medication. And so you really need to treat asthma in a twofold approach. One is to get rid of the inflammation, and the other is to help relax the airways. So the primary treatment for asthma are bronchodilators, or medicines that help relax the airways, and the common one today is albuterol or Xopenex. There's also ipratropium, which has the same effect through a different mechanism. And then we use commonly either inhaled steroids or systemic steroids, oral steroids, to help decrease the inflammation.
I see. What is the best way for parents to help control a child's asthma?
The best way is to make sure they take their medicine.
Okay.
The hardest thing that we run into, the most difficult, is we get a child on medication, he's doing well, we get him on maintenance medication, and most kids that have asthma end up being on a maintenance medication to help keep them stable. And then what happens usually is they feel good. And so either the child doesn't want to take the medication anymore, the parents don't want to give it because they think, well, the child is feeling better, so why should we give him medication? When in fact it's a medication that's helping him function at a normal level. And so the biggest obstacle we have is parents not giving the medication like they should. Now, the goal that we use is to try to help the child maintain normal function on the least amount of medicines possible. And so we're always open to decrease medication or change medication to make that happen, but most of the time what we find is that parents will stop medication when they really shouldn't. The other thing is there are a lot of environmental stimuli that make asthma difficult to control, and probably the biggest factor that we have is smoking. And we have parents or people that live within the house will refuse to stop smoking, which makes asthma much more difficult to control. Even smoking outside the house still exposes a child to varying degrees of secondhand smoke. And when we measure that exposure, we have kids who show light exposure to exposure almost equal to that of a light smoker. So, those are probably the two most common things that we see that make asthma difficult to control.
I see. Well, I think we're going to take a short break right now and come back in just a minute.